Today, I will be talking about ventilator associated lung injury and how to minimize it in clinical practice. My name is Praveen Jain. I am the founder president of the Indian Society of Critical Care Medicine and the chairman of Critical Care Education Foundation in India. Mechanical ventilation is an essential support for critically ill patients. Yet, mechanical ventilation itself can lead to serious damage in previously healthy lungs and more so in diseased lungs. Ever since man started using mechanical ventilation, he has been acutely aware of the fact that it can cause complications in the form of pneumothorax, surgical emphysema, and pneumomediastinum. It was thought that the high pressures that these ventilators could generate is responsible for this trauma, and therefore the term was barotrauma. Hernandez and his team studied rabbits with intact closed chest and compared it to similar rabbits who had a full body cast so that the thoracic volume could not increase. And he then ventilated them with a peak pressure of 15, 30, and 45. And what he found was that in those with a full body cast, where only the pressure went up and the lung volume did not increase, there was very minimal evidence of lung injury. But in intact closed chest rabbits with increasing peak inspiratory pressure, the lung volumes increased and also the evidence for lung damage increased. He rightly concluded that volutrauma is more relevant than the term barotrauma. Another form of ventilator-associated lung injury is called atelectasia. This is a form of repetitive injury from the opening and closing of alveoli at low lung volumes. If you blow a balloon, you know that it requires higher pressures initially to open the balloon, and then inflating the balloon becomes much easier. If the lungs were to collapse with each expiration and similar high pressures would be needed each time with each breath, causing shearing injuries and inflammation. Imagine now multiplying this injury by millions of alveoli in each of us 18 to 20 times a minute. Arthur Slutsky in 1997 showed that ventilating the lungs with zero PEEP can significantly increase the TNF-alpha levels, and the application of PEEP as low as 10 centimeters of water reduced the TNF-alpha levels from 1200 picograms per ml to below 100. In ARDS and acute lung injury, the lungs are inhomogeneously affected, both macroscopically as seen on the CT scan and microscopically at the alveolar level. This causes a problem of its own. What is biotrauma? When two adjacent alveoli have different compliances and they are ventilated, the normal alveoli would expand, whereas the stiff alveoli would not, and this would generate a tremendous shearing, tearing stress in between the septum, in between these alveoli. Let me demonstrate this using an animation. As you can see, the normal alveolus with surfactant is opening, the stiff lung is not, and this is causing a red inflammation between the walls. You can also see that these inflammatory mediators enter the alveolus with the normal surfactant, destroying the surfactant, and here the surfactant has become much less, making this normal alveolus now a stiff alveolus. Now, what happens to the inflammatory mediators which go into the bloodstream? Because we know that the lung has an extremely rich blood supply. What happens is these mediators are then carried by the rich capillary supply of the lungs to distant parts of the body and can affect each and every part of the body, like the liver, the spleen, the pancreas, the kidneys, the blood, etc. Less commonly appreciated fact is that respiratory rate also can cause ventilator-associated lung injury. Hotchkiss did this experiment where he ventilated 2 sets of rabbits, giving them the same tidal volume, same peak and plateau pressures, and same PEEP. One was ventilated with a respiratory rate of 3 and the other with a respiratory rate of 20. And what he found was that the evidence of lung injury in the form of weight gain, edema of the lungs, etc., was much, much higher with a higher respiratory rate than with a lower respiratory rate. It is not difficult to understand that if we are promoting low tidal volumes and low respiratory rates, these patients on the ventilator are going to develop hypoventilation and an acute respiratory acidosis. What is the consequence of this respiratory acidosis? Many studies, like those by Sinclair and by Brochard, have shown that hypercarbia is in fact protective of the lungs, and hypercarbia causes less lung injury, either chemically and even histopathologically, where the hypercapnic rabbit alveoli here are much better preserved than the normal capnic rabbits with so much of alveolar inflammation. So how do I minimize ventilator-associated lung injury? There are various things that we have seen. Use a low tidal volume of 6 ml per kg ideal body weight. 2. Avoid a high respiratory rate, more than what is normal. Keep the airway pressure, the peak airway pressure, less than 30 centimeters of water. Use a safe FiO2. Use appropriately high PEEP to prevent cyclic de-recruitment, and we shall see what appropriate high PEEP is. Use a recruitment maneuver to minimize biotrauma, and this is very important. Don't just rely on the fact that you've applied PEEP. Consider a neuromuscular blocking medications, and this is optional because we don't want to induce critical illness myoneuropathy. Consider combining prone ventilation in severe cases. Now let's see this with this balloon example. We already saw that the lungs in ARDS patients are very heterogeneous. Alveoli have different degrees of stiffness. So when you inflate them, some alveoli will expand to normal, some will overexpand, some will underexpand, and some will not expand at all. If the alveoli are side by side, you can imagine millions of alveoli with different compliances, how much of biotrauma would be produced. What we want to do is to use mechanical ventilation in such a way that at end inspiration, most of the alveoli are open to the same degree. It is a common misconception that PEEP opens the lung. PEEP is an expiratory phenomena, positive end expiratory phenomena. The peak inspiratory pressure is what opens the lung. So opening of the alveoli is an inspiratory event. It is by the peak inspiratory pressure. So what is the importance of PEEP? Well, once the alveoli have been opened by the peak inspiratory pressure, PEEP keeps the alveoli open. It prevents it from collapsing and therefore prevents atelectroma and biotrauma. It is easy to understand that the amount of PEEP required will depend on the stiffness of the alveoli in that particular patient. Here you can see on the CT scans that just applying PEEP, even if it's high, does not recruit the alveoli, and you must in addition do a recruitment maneuver, and you can see the vast difference with the same PEEP that the recruitment maneuver gives to the patient. But how do you assess recruitment at the bedside? We cannot get CT scans done in our ICU patients all the time. Well, you can definitely use an X-ray chest, but the most sensitive thing is to use a PaO2 FiO2 ratio. We know that in a normal lung, the PaO2 FiO2 ratio is more than 500, which means all alveoli are open. Now let me give you an example. If a patient with ARDS on ventilator on 100% oxygen has a PaO2 of 70, and you do a recruitment maneuver and the PaO2 now, PaO2 FiO2 ratio now comes to 250, well, definitely oxygenation is improved very well and you may be able to reduce the FiO2. But it also means that it is short of 500. 250 out of 500 means that only 50% of the alveoli are now contributing to ventilation and are working, 50% of the alveoli are still collapsed and producing cytokines, and they will affect your patient outcome. In the famous ARDS net study, which compared low PEEP and high PEEP, I feel that the study design was flawed because keeping an oxygenation goal of a PaO2 of 55 to 80 with various combinations of PEEP and FiO2 resulted in a PaO2 FiO2 ratio which was very low. Using 40% oxygen, a PaO2 of 55 meant that the PF ratio would be 137. This means only 27% of the alveoli are open and 73% are producing mediators. Same way, if you use another combination on 70% FiO2, a PaO2 of 80, which would be acceptable by this study design, it results in a PF ratio of only 114, which means that 77% of the lung are still producing mediators. How do you expect to have a difference in outcome when both your groups, 75% plus minus 2% of the lungs, are continuing to produce mediators? Well, this was beside the point, but it stresses the importance of the PF ratio in evaluating how much you have recruited the lungs. There are various types of recruitment maneuvers. There is sustained inflation. There is recruitment maneuver followed by a decremental PEEP titration, also called the open lung approach. And then you have prone ventilation with or without a recruitment maneuver. Sustained inflation is surprisingly a very common and popular method of recruitment. You set the ventilator to CPAP mode and then increase the CPAP pressure to 30 to 40 centimeters of water for 30 to 40 seconds. ARDS net study again used the same thing. They applied a CPAP of 35 to 40 for 30 seconds. And the conclusion was the response to recruitment was highly variable. Now, I find this not surprising at all. Are we trying to fit one size for all? One CPAP for all people? It's a no-brainer that to stop a cycle, you will need less pressure than to stop a scooter, than to stop a truck. Same way, the PEEP that you will need to apply will depend on how stiff the lungs are and how low the compliance is. So one size fits all is not going to be a safe, effective way of recruiting the lungs. What we need is a custom-made approach where a stepwise recruitment maneuver is done. Clinical and experimental data has shown that a pressure-controlled approach with stepwise increase in peak inspiratory pressure to recruit the alveoli is not only more effective but has less hemodynamic compromise than using CPAP. How do I open the lungs? Lachman, in his monumental paper, Open the Lungs and Keep It Open, published in 1992 in Intensive Care Medicine, said that we are starting with closed alveoli, collapsed alveoli. We need to open them up till we find a pressure at which most of the alveoli are recruited, and this we will call the opening pressure. Then we will reduce the peak inspiratory pressure till we find that the alveoli have now started to close. This we will cause the closing pressure. Then we will reopen the lung and we will prevent it from closing during expiration by using adequate PEEP. Now, in the dissected animal lung model, here is an ARDS lung. With each picture, the incremental pressure increases by 4. So from 0 to 4, lungs are closed. 8, lungs are closed. 12, lungs are closed. At 16, the lungs open up. This becomes the opening pressure. Now, if we decrease the peak airway pressure, 16 to 12 to 8 to 4, the lung remains open, but below 4, the lung collapses and closes again. We will see this in the fall in PaO2 FiO2 ratio. This would be called the closing pressure. Now, we will reopen the lung by taking it to this pressure, and then we will prevent it from collapsing or closing by keeping the PEEP at 4 millimeters higher higher than the closing volume. So how do I do it? I determine the opening pressure, I determine the closing pressure, I reopen the lung and then optimize the PEEP to keep the lungs open. I will now take you step by step through the actual procedure that is followed. It may vary in different institutes, but I find this most customized to the patient and safest. First of all, I use a pressure control mode. I then set the IE ratio to 1:1. I set the peak airway alarm very high, at least 70. It may go higher to even 90. And I switch the FiO2 to 100% only because it's easier to calculate the PF ratio. I then set the PEEP on 20, empirically on 20, and the peak airway pressure at 35. I do this to check whether the patient is hemodynamically stable. If not, I would give 1 to 2 liters of fluid fast so that the hemodynamics stabilize. This is not recruitment. Even though the PEEP is 20, this I call pre-recruitment. Now I start my recruitment maneuver. Of course, at every step here, I've done the blood gases only to demonstrate what is happening. We don't do it so frequently. So at this time, the PO2 was 106 at pre-recruitment. Now I increase the peak airway pressure to 40 for 30 seconds and bring it back to 35. This results in an improvement in the PO2, but it is far below the 500 we expect. I now increase the peak airway pressure to 45 for 30 seconds, see the blood gas, go up to 50 for 30 seconds and then again come down. And now I've got a PO2 which is acceptable. I call this the opening pressure. Now having got the opening pressure, I will try to get the closing pressure. But you must note that we started with a PEEP of 20 and a peak airway pressure of 35. We have now again at the same value of PEEP of 20 and peak airway pressure of 35. But the difference is from a PO2 of 106, we have reached a PO2 of 502. Now we are determining the closing pressure by going down on the peak airway pressure from 35 to 33. The blood gas is holding. 31, blood gas is holding. 29, the blood gas falls. The PO2 falls. And therefore, this becomes my closing pressure. So I've determined the opening pressure. I've determined the closing pressure. Now I need to reopen the lung, which is not going back to here where it was open, but going to 50, which is what my lungs were opening at, and then coming back, but not to 29 where it was closing, but to one step before that, so 31. I've got now a lung that is open. My PO2s are again established. I've determined the opening pressure. I've determined the closing pressure, but I've not optimized the PEEP. The choice of 20 was empirical. Now I'm going to go down on the PEEP and see how the patient behaves. From 20, I go to 18. PO2 is holding, I go to 16. PO2 is holding, I go to 14, and the PO2 drops. That means the PEEP that is required to sustain the lungs, as I told you, with each patient has a different lung compliance. You need to determine the PEEP that in that patient at that time keeps the lung open, and that in this case is 16. So I will put the PEEP on 16. I will reopen the lung and then keep it open at 31. So now I've set everything appropriately. But the final step is I don't need 100% FiO2 and a 510 PaO2. I will bring down my FiO2 to 40. And we know that one of the risk factors for ventilator associated lung injury is a high FiO2. We have now been able to bring the FiO2 down to reasonable limits. In summary, we started with ventilating this patient who had a PO2 of 106 on PEEP of 20, peak airway pressure of 35. Within 10-15 minutes, we've been able to bring the PO2 from 106 to 510. The peak airway pressure has in fact fallen, reduced, and the PEEP has reduced, and we have optimized it. And it is not uncommon to see such dramatic magical opening of the lungs even on the X-ray chest. Thank you for being such a lovely audience. I know the steps here are much more complicated than putting on CPAP of 40 for 40 seconds or CPAP of 35 for 30 seconds, etc. But it's not going to be easy. It's going to be worth it. Thank you very much.